Perfect. Okay. My name's Kyle Crawford. I'm a CRNA in Chattanooga, Tennessee. I'm presenting today on Sugammadex, Reversing Tradition. My committee members are Dr. Joni Jackson and Dr. Corey Carpenter. So the background of my study, that in the operating room, non-depolarizing neuromuscular blockade is used daily. It helps us facilitate intratracheal intubation, optimize surgical exposure, and provide mechanical ventilation to our patients. Anytime steroidal non-depolarizing neuromuscular blockade is utilized, reversal must be administered prior to the resolution of the case in order to facilitate intratracheal extubation. Historically, this is done with acetylcholinesterase inhibition. This works by inhibiting the breakdown of acetylcholine at the synaptic cleft. The increased acetylcholine competitively inhibits the neuromuscular blocking agent, allowing it to become unbound and metabolized. Now, as we know, acetylcholine doesn't just work at the motor neuron, it works all over the bodies at any muscarinic receptor site. And anytime you stimulate this with an influx of acetylcholine, you can have the side effects of bradycardia, nausea, bronchospasm, hypersalivation, and abdominal cramping. So this is why anticholinergics must be paired with the administration of acetylcholinesterase inhibition for traditional reversal. So how is depth of blockade quantified? So Trainophore monitoring is utilized at my practice setting, which is the utilization of a succession of 4 twitches, electrical twitches that create an impulse that cause a muscle twitch. Okay, so this is subjective in that the provider must identify not only the presence but the strength of each individual twitch. An optimal reversal is actually a Trainophore ratio of 0.9, where the 4th twitch is 90% of the first twitch. So the issue here is that Trainophore ratio of 0.7 to 0.9 is actually deemed adequate. So in this 0.7 to 0.9 ratio, there's actually exhibited symptomology of residual neuromuscular blockade after reversal. So these symptoms are impaired pharyngeal tone, impaired laryngeal tone, impaired cough reflex, potential of aspiration, and potential of respiratory failure. So how often does this happen? So O'Reilly Shaw and Associates in 2018 found that this incidence is as high as 60% after traditional reversal. And Bolka and Associates in 2016 postulated that this residual neuromuscular blockade has increased the likelihood of postoperative pneumonia by up to 1.79 times when utilizing traditional reversal. 2020 Stronger study is a multi-center United States-based study with a 45,000 participant cohort grouping, found that 1 in every 76 cases who received traditional reversal developed postoperative pulmonary complications. 1 in every 105 developed clinical pneumonia, and 1 in every 112 developed severe respiratory complications. So how do we fix this? So Sugammadex is a relatively new medication to the United States care model. The FDA approved it in 2015. It works differently than neostigmine in the fact that it works directly. It encapsulates rocuronium, vecuronium, your steroidal non-polarizing neuromuscular blocking agents directly and forms a stable bond, okay? And once this bond is formed, the neuromuscular blocking agents rendered completely inactive. Like imagine utilizing Febreze. You spray Febreze, it encapsulates the odor, and then it's gone. It works very similar, okay? So Sugammadex in itself dose-dependently provides rapid and predictable reversal of neostigmine blockade regardless of the depth. So what benefits does Sugammadex provide? As I was mentioning earlier, it eliminates the incidence of residual neuromuscular blockade when dosed correctly. So this can be attributed to a 30% reduction in pulmonary complications, which is $58,000 per event, 47% reduction in pneumonia, which is $67,000 per event, over a 50% drop in respiratory failure, that's over $80,000 per event. You have a 5% reduction in postoperative nausea, which is the #1 postoperative complication after anesthesia. You have, it's on my pharmacy formulary here in CHI Memorial, Chattanooga, Tennessee. And Sugammadex is a definitive upgrade to traditional reversal, and it's the current best practice standard. So why are we not using it? So Sugammadex is more expensive. It has a higher drug acquisition cost. So a Sugammadex reversal costs $100, where a traditional reversal costs about $14. So the hard sell here to my pharmacy service line is that even though it's $85, $86 more expensive up front, the efficacy and safety and benefit that this drug Sugammadex provides our patients in the postoperative phase offsets the initial increase in drug acquisition cost. So the purpose of my project is to improve patient outcomes after the administration of non-depolarizing neuromuscular blocking agents, improve provider knowledge on neuromuscular reversal techniques, and the incidence and ramifications of residual neuromuscular blockade. I also want to provide a cost-conscious evidence to the pharmacy service line as well as hospital administration. My PICO question was, in anesthesia healthcare providers, how does implementation of an evidence-based Sugammadex protocol compared to traditional neostigmine administration affect the care of adult patients regarding the PACU arrival and PACU discharge times over a 3-month time period? I was able to start with over 300 articles and able to wean it down to 11 articles as far as my literary review goes. And this is an ongoing battle. Neostigmine and Sugammadex trials are just now coming to the United States care model because, like I said, it was just approved in 2015. All these bigger cohort studies in the United States are just now kind of coming to the forefront of academia. As I mentioned earlier, Kacher Paul and Associates in 2020, that 2020 45,000 participant study found that Sugammadex was safer. They investigated all these patients and compared Sugammadex across neostigmine with regard to their postoperative pulmonary complications. Another one to pay attention to is Lee, Money, and Elliott in 2019. This hospital closely mirrored CHI Memorial, where I practice, in their patient load as well as their patient population. They found that Sugammadex was faster and more efficient when compared to traditional reversal. And then for every 1,000 patients, they saved almost $500,000. So my short-term outcomes, my short-term goals were to decrease the time of surgery in to PACU arrival time by 10%, decrease the PACU length of stay by 10%, decrease the incidence of pulmonary postoperative complications by 20%, to increase provider knowledge by 20%. Long-term, I wanted to increase provider knowledge by 30% regarding Sugammadex and residual neuromuscular blockade incidents. And long-term, I wanted to decrease the observed PACU arrival time and then PACU length of stay. Overall, I wanted to create a more open culture as it relates to patient benefit and cost-competent care. As I mentioned repetitively here, CHI Memorial in Chattanooga, Tennessee was where I implemented my project. I had 108 CRNAs, 29 anesthesiologists, and 12 in our OR pharmacy department. I mentioned one of the primary barriers to implementation of Sugammadex in a broad sweeping fashion is the pharmacy's reluctancy for open administration secondary to Sugammadex being a more costly drug up front. I also mentioned that anesthesia providers are just now being exposed to this brand new information that's coming regarding Sugammadex's benefit in the United States care model. So brand new information is popping up every day, and this project provided an educational exposure with brand new US-based information to afford their patients. I conducted a quality improvement project that was dual-headed. I did a chart review as well as staff education. So with my chart review, I did a pilot study of 50 patients that were undergoing thoracoscopy or thoracotomy procedures. The first 25 patients who received Sugammadex and the first 25 patients who received traditional reversal were followed with regard to their PACU arrival times as well as their PACU length of stays. The goal of this was to improve the quality of patient care by decreasing the incidence of postoperative complications that are attributed to residual neuromuscular blockade. I afforded my clinical staff, the anesthesia staff at Memorial Hospital, a pre-hoc survey, and then provided anesthesia education on neuromuscular reversal tactics, the effects and ramification of residual neuromuscular blockade, and the rationale for these tactics. And then provided a post-hoc survey and extrapolated quantitative and qualitative data from the staff answers. This is the CHI Sugammadex protocol that I helped champion with the Pharmacy and Therapeutics Committee. As you can see on the top, for routine reversal, traditional reversal is still utilized, and this is something that we're working towards potentially maybe moving away from. Three important areas below that you can look at is in the presence of a failed reversal, which is the administration of the max dose of traditional neostigmine-based reversal, Sugammadex can be used. And this happened multiple times in my chart review study, and I'll talk about that in just a second. In patients who are on the right, on the patients who are on end-stage pulmonary disease, as you can imagine, patients undergoing thoracoscopy and thoracotomy procedures are potentially more likely to have pulmonary crippling. So any patients whose FEV1 is less than 30 or currently on oxygen therapy at home qualify for Sugammadex. And right under that, in dense neuromuscular blockade, when you have a 0 out of 4 train of 4 at the resolution of the case, there's always the chance that you have a more dense motor blockade than intended at the end of a case, especially when you're trying to render the patient's diaphragm immobile and facilitate safe surgical exposure. So that would qualify the patient for Sugammadex utilization. My financial expenses, so grossly $8,000 is what it costs to implement my project. That's the cost of the medications as well as the 30-minute education sessions I afforded my staff. I expanded the values that I quoted earlier from the Bureau of Labor Statistics and the Center for Medicare and Medicaid regarding the reduction in complication rates postoperatively, and then further expanded that to the grossly 13,000 cases per year that my hospital utilizes neuromuscular blockade. So there's a potential cost savings of $3 million just by the reduction of pulmonary complications. The 47% reduction in pneumonia is a $4 million in savings. Over a 50% drop in respiratory failure is $5 million in savings. The 6-minute change in care delivery times is grossly a $7 million in savings. So you put all those numbers together, and there's a potential benefit of $19 million per year just by transitioning from neostigmine utilization to Sugammadex. So my project outcomes. So I mentioned that I followed surgery in time to PACU arrival times. Now I will get in front and say that if I were to repeat this study, I would make a third group. I would make a neostigmine group, a Sugammadex group, and patients who receive Sugammadex as a rescue for a failed reversal. Being that I only had 2 groups, any patient that received Sugammadex, regardless of whether it was a failed reversal or not, were lumped into the Sugammadex group. So I think that's why the initial here, the 45-second difference between Sugammadex and traditional reversal, Sugammadex patients technically took 45 seconds longer to get to PACU. This in itself is a very small portion of time, and that could be attributed to provider variance. It could also be attributed to the patients being potentially more pulmonary compromised because they actually qualified for the Sugammadex administration to begin with. But when you look at PACU length of stay, regardless of whether the patient received Sugammadex for a rescue or not, it's not going to change the ramifications and incidence of residual neuromuscular blockade. So Sugammadex in the PACU setting decreased the PACU length of stay by 10 minutes when compared to traditional reversal. So that's a 9-minute and 15-second savings per case. So you expand that to the more broad sense of the entire year's worth of OR cases. There's a potential of $2.7 million in savings per year. And when you factor in the $84, $85, $86 price difference between the 2 reversal techniques, is a $1.664 million savings per year, or $128 per case just by transitioning over to Sugammadex when you're just looking at these 2 parameters here. So regarding my staff surveys, I looked at confidence regarding the actual protocol and Sugammadex in itself, as well as clinical application of knowledge. So I found that there was improvement across the board. There was a 27% confidence improvement on my staff regarding postoperative effects of Sugammadex, a 17% confidence improvement on Sugammadex clinical indications, a 19% improvement on staff confidence regarding Sugammadex dosing, and a 15% improvement in finding the dosing parameters of Sugammadex. That's really important when you're thinking about things, because whenever you're utilizing as a healthcare provider, you don't want to utilize a intervention that you're not confident in. The decrease in confidence and decrease the amount of times that you utilize an actual intervention will further precipitate lacking of utilizing it in the future. Okay. Now, when you look at the clinical improvement, I did clinical application knowledge, and there was a 12% increase in providers correctly identifying the CHI routine reversal, a 9% improvement in dosing of the neostigmine before the patient can be deemed a failed reversal. And those smaller numbers and statistically insignificant, the clinical qualifiers for Sugammadex had a 3, 4, and 8% improvement. Okay. I think this is partially due to my questionnaire. I made a multi-correct answer questions here, 3 of them, and all the incorrect answers were kind of gray zones that were very intriguing to click on. I think that if I made a little more straightforward question, that those numbers would be much higher. But when you look at the big picture here, not only is the staff's confidence in this clinical intervention improved, but their application of knowledge has improved clinically here. So not only is the staff more confident in what they're doing, but they're actually able to apply a beneficial intervention to their patients more effectively and know the rationale why. So I utilize Rogers' diffusion of innovation theory for my project. It really encapsulated the entire idea that my project was founded upon, which is the instituting change into a given body. Now, being that this theory is not a healthcare-based model, it doesn't necessarily directly encounter the patient, but it's in here. So basically, what Rogers postulated is that an individual with knowledge that wants to create change must, to an audience, persuade them. Okay, and then after the persuasion happens or it's facilitated, the audience has the ability to make a decision. Either they adopt the change or they reject the change. So once the individuals decide that, they get to implement either their adoption or their initial rejection. And over time, they either get positive or negative confirmation on whether their change in practice was beneficial or not, or the rejection was beneficial or not. So they have the opportunity to change their initial decision later on. So the 5 most important characteristics of innovation, as identified by Rogers, was the relative advantage. Okay, so does this change actually provide benefit over the practice care settings that you've been implementing prior? Okay, is there compatibility with the individual's ethics? So does this change combat any preconceived ethical parameters that the provider has going into this potential change? Is the change overly complex, or is it more complex than the previous practice? So Sugammadex in itself is actually much less complex when administering than neostigmine-based dosing. It's faster, it's more efficient, and you don't have to worry about correctly dosing and giving the patient time. It takes anywhere from 15 minutes to 45 minutes really to hit peak effectiveness with neostigmine and the anticholinergic pairing, and you're talking about anywhere from 3 to 5 minutes for Sugammadex to hit its peak effectiveness. Is there a trialability aspect to this change? Is the clinician able to try the change and potentially walk away from it later if they don't like it? Is there an ability to not be married to it? And is there observability of positive benefit? So is the practitioner able to see positive effects with the change in their practice observable in the clinical setting? My sustainability plan is to develop a framework for continued investigation of postoperative pneumonia, postoperative nausea and vomiting, and urinary retention. I plan to present my study in cost analytics to the pharmacy and therapeutics department and the committee. I plan on proposing a further pilot study into other surgical subspecialties. I plan to disseminate multiple levels in the CHI Memorial care setting where the pharmacy department chiefs, the Memorial financial executives, as well as the Memorial Pharmacy and Therapeutics Committee. And I plan on disseminating the Tennessee Association of Nurse Anesthetists Conference either by formal presentation or by poster presentation. Though I encountered all my DNP essentials, the 4 primary essentials that really were footed in my project were essential 1, 2, 6, and 8. DNP Essential 1 identified a patient safety gap that was inherent in my practice in Chattanooga, Tennessee, with regard to residual neuromuscular blockade being present in the postoperative setting. I implemented measures to improve patient safety and disseminated the Sugammadex protocol more efficiently and educated staff. 2, I developed and championed the Sugammadex protocol with the Pharmacy and Therapeutics Committee and used communication to lead healthcare initiative change. 6, being that my project's a multidisciplinary, multi-department-based project, communication and collaboration was imperative on every level. There's individuals with different care settings, different angles at which they work. So being able to communicate effectively was imperative. And then 8, with the Sugammadex protocol, I designed and implemented and evaluated therapeutic interventions of neuromuscular blockade reversal and used the analytics in evaluating links among practice, organization, and fiscal issues that were inherent in the CHI care model. These are my references, and I just wanted to open it up for questions and thank you all for your time.
Thank you, Kyle. I'll open it up first to Dr. Jackson for comments. I also see that Dr. Carpenter is with us. So Dr. Jackson and Dr. Carpenter, would you like to begin?
Dr. Carpenter, go ahead, please.
Hey, Dr. Jackson. Sorry, I had to get ready to ask questions. Kyle, I really appreciate your presentation, and I definitely agree with your thought about having 3 groups. If we were to do the study again, it would be interesting to see how big of a difference it would have made to have one of the groups just receive Sugammadex only, and to see how profound of a change that would have made. But other than that, I think it was great. Now I think you presented it well and clearly, and don't really have any other further questions.
Thank you.
Thank you, Dr. Carpenter, for sticking in there with us. Kyle is an example of someone who has gone extended options. So those of you on that route know that there is success at the end of the road, and soon to be Dr. Crawford will be a living example of that. So thank you, Kyle. Great job.
Thank you.
Do we have questions or comments for Kyle?
This is Dr. Hill. Congratulations.
Thank you.
As far as TANA dissemination presenting there, you know 2 CRNAs really well who are now on the program committee for that conference for next year. So you just went to the top of our list of potential speakers. This will be great data to present. Thank you.
Here's the list, Kyle. We'll put your name right here.
Right.
Do we have other questions or comments for Kyle?
Kyle, I guess if you don't mind just kind of elaborating, just because I am so interested in the part about, you know, working with and speaking to the pharmacy specifically, because there are a lot of drugs I feel like we come across at Erlanger that we'd really like to use more and you know, feel strongly about. How was that experience? You know, working with them, how were you able to you know, did you feel like you were able to be convincing, that kind of thing?
I'm going to answer your question. My roommate just decided to go off and intervene. Let me just hit the stop button real quick. All right, just wanted to make sure you can hear me. So being that you work at Erlanger and I'm at CHI Memorial, the systems are set up a little different. So you can talk to Erlanger and kind of get to the meat and potatoes a little easier than I can. So when I'm talking to not just the Pharmacy and Therapeutics Committee, the directors of that, the pharmacy heads, you know, it's a tough sell for them because it's not just them making a decision. They have to send their ideas up a level, and then that level is then to the national level. And so you really have to you can't just come to them in a piecewise fashion and say, hey, what do you think about this? You have to really give them really solid data. And that's been the issue prior to this, and why Sugammadex hasn't been utilized, is they have quoted and said that though we see that Sugammadex is a better drug, neostigmine is adequate. And that's literally what they say. And I hate that sentence because that is not a patient-driven model.
I know, I hate that sentence too.
Yeah,
a terrible sentence.
Yeah, but all that they see is the fact that, like I said, $14 versus $100, and they're okay with their post-operative care right now, and because they have blinders on. So it's not just only presenting that data to your pharmacy department, but also going like around the corner and talking to the financial executives, because you can sit here and say, there's this data all over the world, and we're just now getting this data in the United States. but I've got you data here in Chattanooga with your patients to show you that you can save this amount of money. And it's not just money, like you're reporting these patients a safer hospital throughput with less postoperative complications. And you really kind of have to hit it from multiple angles. It's not just a clean, go and talk to this one person and you're going to tweak it. Now, I think at Erlanger, you're able to get to the top a little quicker because it's a little more in-house than, you know, being like a CHI or an HCA conglomerate. But you really, like, I would tell you, if you were going about that path, is really getting all your information all together and being ready to come back and give them real facts.
Well, I really enjoyed your presentation. I think it's a wonderful drug, and I think your findings are very interesting.
Thank you.
Thank you so much, Kyle, for the comments and following up. We'll move on now to